We're going to go ahead and get started, everyone. Thank you all for coming tonight. All right, I hope everyone can see my screen okay. Welcome to a summary of men's health with Dr. David Chang. Just a few quick notes before we start the presentation. Please keep your microphone muted during the presentation. This helps cut down on background noise. Please hold your questions until the end of the presentation, and you may use the chat box when asking your questions. Captions are provided for this event. You can press the captions button at the bottom of your screen to view captions, and the link for Spanish captions is in the chat box. A few days after the event, everyone who registered will receive an email with an evaluation form from both the library and from our grant sponsor. Please consider filling out the evaluation forms as they greatly help us provide and improve future programming. On the behalf of the library director, Sai Rao, and our library staff, I would like to start by thanking Hackensack Meridian Palisades Medical Center, Nikki Medeiros, and Dr. David Chang for generously donating their time to organize and appear at this event. We greatly appreciate you being here. I would also like to thank the National Network of Libraries of Medicine, Middle Atlantic Region, a partner of the All of Us Research Program, for providing a grant funding tonight's captions. The All of Us Research Program aims to build one of the largest, most diverse collection of data of its kind for health research. The goal is to have 1 million or more diverse volunteers nationwide who will sign up to share information over time. The goal of the program is to help researchers understand more about why people get sick or stay healthy. By looking for patterns, researchers may learn more about what affects people's health. To learn more about the All of Us Research Program, visit www.joinallofus.org/NLM. Dr. David T. Chang is board certified in urology. He offers this full spectrum of university-level urologic care at Palisades Medical Center in North Bergen. His clinical interests include kidney, bladder, and prostate cancer, prostate enlargement and voiding problems, kidney stones, erectile dysfunction, urinary incontinence, vasectomy, and laser surgery. Dr. Chang finds the most rewarding aspect of urology is the ability to work together with patients to improve their quality of life. With more than 20 years of experience and foundational training with Harvard College and Columbia University, he combines traditional and cutting-edge techniques to deliver individualized treatment plans with an emphasis on superior quality, great outcomes, and patient satisfaction. All right, and without further ado, I will stop sharing my screen and turn things over to Dr. Chang.
Okay, welcome everyone. Thank you for coming. Let me turn on my screen. This works okay. Everything good there? Okay. So I'm Dr. Chang. Thank you for coming. I thought that we'd just take a few minutes to go over a few topics that are very common for men to go through, experience, and see if I can just give you a little information about that. And then we'll have some time for questions at the end. So, as she said earlier, I did train at Harvard and Columbia. I'm originally from Buffalo, New York. I'm kind of used to all this cold weather and all that. I actually finished my training and started practicing urology all in New Jersey since the year 2000. And just recently moved to Palisades Medical Center, where I've been continuing to practice and serve the community here. And it's been a real pleasure. So I think trying to prepare, there's so many things that men's health or urology for men kind of encompass. We do also treat women with a lot of problems, but for the purposes of this talk, I wanted to just narrow things down. And even then it was difficult. I'm left here with 3 real common things that we get asked about and things that we treat. And you see them on the screen, including prostate cancer, BPH, which is a benign prostate growth condition that causes urinary problems, and erectile dysfunction. So we'll go ahead and start. I'm going to try to just go over a little bit about each one and give you some information. And let's see if we can't go through this here. So prostate cancer. This is a it's a cancer that is really kind of in the news. It certainly ranks up there with very, it's a very sort of important thing to think of for men as we are getting older. This is just statistics. It shows you the number of new cases, estimated deaths. The time down here is kind of more of a fun sort of factor in a way, just to get some idea. But in reality, I just wanted to show you this information to drive home the point that this is a significant problem, and that men should consider this in their treatment and diagnosis, because if caught early, like with anything else in medicine, most things, if you catch things early, you have a real good chance to get through it in an easier and successful fashion. So a little bit more about statistics, just so you get some idea of what we're dealing with. The lifetime risk of a man of getting diagnosed with cancer is 10–11%, which is not a small number. And the lifetime risk of dying from it is 2 to 3%. This is, again, I use this just to show you that this is something that is quite important. There is some sort of racial differentiation in terms of risk, and the reason for it, we don't know why, but these are just purely observed statistics. African-American men seem to have a little higher risk, going down through these numbers through Hispanic, white men, and Asian men. This is kind of interesting that we learned, and I thought I'd pass it on. Just even though the risk of getting it is 10 to 11%, the risk of dying from it is 2 to 3%, look how many people actually have it. So when they do autopsies on men who would have died from other reasons between this ages of 50 and 59, can you believe almost 1 in 5 actually have prostate cancer? And look at these numbers for the older men. 1 out of 3 men actually have prostate cancer. So this, taken together with these numbers up here, kind of tell us that a lot of men have prostate cancer, but either it's not diagnosed or it's not really causing any sort of clinical effect for them. But this is something to keep in mind as we kind of move forward here. Kind of the one of the most common questions we get asked about prostate cancer is, should I get screened for it? This is something that, men understandably are not crazy about doing. As you can see, part of the screening process is a digital rectal exam. The purpose of that, I tried to include this to show you. Here's the prostate right here. We got the bladder and the penis and the urethra come this way. The doctor would put his finger in, and we're just feeling the back of the prostate right here, right through the rectal wall. The purpose of that is that that's most commonly where tumors are found. Sometimes you can actually feel them, but more commonly, we will also include as part of the screening the PSA blood test, which is an important test to try to assess a patient's risk of having cancer. If either of these is abnormal, the next step in trying to see if it's present or not is a prostate biopsy. That's a similar procedure as this, with a different instrument to take a few samples of the prostate and analyze it. Now, there's been a lot of debate that you might have come across in media or publications. Should I get screened for prostate cancer or not? We do screening for colorectal cancer. Women get screened for GYN and breast cancer. But because not everybody dies from prostate cancer, this is a real sort of controversy. So here's the actual sort of official guideline from the U.S. Preventive Services Task Force. They suggest that the men in this group, age 55 to 69, is the group that can benefit the most from screening for cancer. If you're younger than that or older than that, it's unlikely you're going to find a cancer in time or find a cancer that's going to actually affect the patient's lifespan. So they tell us doctors in this age group, 55 to 69, have a discussion with the patient. It's not a mandatory thing that you must suggest for them. It's an individual choice. It's a pretty clear recommendation. Men over 70, they do not recommend screening. Now, keep in mind, these are recommendations by the task force. And again, in thinking about it, a lot of people do have cancer, but it may not be that significant. So what are we supposed to do? These are the arguments that people say you don't really need to screen. If you look at these public health people and all their statistics and How many lives can we save by screening? Are we spending too much money with all the blood tests and biopsies? We can prevent 1.3 deaths per 1,000 men over 13 years, which if you think about it, it's not that much in terms of how many people you're actually helping from dying. Because of that, and because the lifetime risk is dying is 3% or so, but so many men have it, public health people are worried, and understandably so, that a lot of men maybe are getting treated for cancer who may not even need to be treated. You may be one of the 33% who die with the cancer and not from it, as we say. My feeling is this, I'm just going to pass this on to the audience. To me, it's still better to know rather than not to know if you have the cancer. The lifetime risk of dying from it is not 0. It's 2 to 3%. Now, if somehow magically you can know you are one of those 2 to 3% of men who will die from it, or your loved one, I'd rather know about it than not know. We waste a lot of money in healthcare, and to me, why should I be denied that knowledge if potentially I could be saved? There are treatments for cancer that are very effective and relatively easy to go through these days, including surgery, radiation, even surveillance, which is to keep a close eye on things. So my feeling is, I think the danger is not really in the diagnosis necessarily of the cancer, and the problem is you have to know who to treat, who needs treatment, and who you can kind of keep an eye on. You don't want to expose patients to a lot of side effects who maybe have one of these benign, slow-growing kinds of tumors. So I would pass this on to just you guys, be informed. Don't be afraid of screening. Like with anything, if you have it, it's better to know about it and deal with it. But just see an honest doctor who's not going to treat you if you don't need it. That's sometimes difficult to know what you're getting. You can get a couple different opinions if you get into that sort of situation. Okay, so that's kind of a little bit of overview about prostate cancer. That some of the things we get asked about a lot. Now, the next section I wanted to discuss relates to a condition called BPH. It's called benign prostate hypertrophy or hyperplasia. So getting a little bit more into the prostate, it's kind of a little bit of a mysterious organ for a lot of people. We know about it, we don't know where it is necessarily. This is just a sort of anatomy kind of picture of what we're actually talking about. In this side view, you can see once again, the bladder is here and the prostate is right here. And here's the urethra coming out through the man's penile area. This is another sort of three-dimensional view of this. This tube here is intended to visualize the urine channel right as it comes through the prostate and out. I kind of tell my patients sometimes I visualize it like an apple with a core cut out through the middle of it. And you have to pass the urine right through the middle of this core here. These blue things are other glands called the seminal vesicles. They contribute some of the seminal fluid. Everything meets up in here. And in an orgasmic situation, that's where the fluid comes from and comes out through the penis. So I show this just so you have some idea of where the prostate is, and you're going to hopefully get an idea of why this can actually cause another problem for men, which is some problems passing the urine. If you look over here, you'll see that it sits right at the opening of the bladder, and there's a tube that runs right through the middle of this thing. So this is not the most ideal place to put the prostate, and what can happen is it can grow, usually under the influence of testosterone as well as some other factors. And eventually it can lead to some problems with urination. So we have the prostate. The first thing we talked about was cancer, which is a growth in the prostate that's not normal. It doesn't stop and it has the potential to spread through the body, and in which case it can really do some bad things and even lead to death. Here we have benign growth. So benign growth is kind of like your hair grows. This is a growth, but it's not a cancerous growth. We get skin tags. They're growths, but they're not cancerous growths. Here, the prostate can grow in a benign fashion, but here there's a schematic that tries to show normal prostate with that urine channel running through the middle of it. And here we have a prostate that grew. It can grow larger sort of outwards, but it could also grow larger inwards to narrow down that apple core or the tube that you have to urinate through. Now understand, sorry, my dog is here. I'm at home. So here's the bladder trying to push urine out through the channel here. It's almost like plumbing. So you can imagine if it's blocked, these are some of the symptoms you can get. This urinary stream can be slowed down. Men sometimes feel it's hard to initiate their stream. The volume of urine that comes through can be smaller than usual because you start, but then it peters out because you just can't overcome the resistance. Other symptoms include frequent urination. What happens is if the bladder is full of urine and you squeeze some out, but you can't get it all out, very soon you're all full again and you got to pee again. So this is a very sort of common symptom of urinary frequency, and associated with that is getting up at night to urinate, which is an extremely bothersome symptom that many of our men suffer from. Same reason. You try to empty the bladder, but instead of getting down to an empty situation, there's still urine there. And next thing you know, a little more comes in from your kidneys and you reach the point where you feel the urge to go again. Finally, we have urinary urgency, another sort of common complaint. This is a situation where the prostate can grow in such a way to sort of sometimes just grow in here and irritate the bladder, but also the bladder muscle becomes very sort of spastic, overactive, overzealous in a way because it's always full, and it gives that sensation of I gotta urinate and it wants to squeeze. Sometimes you can't make it to the bathroom in time. It's that serious. So these are some of the symptoms you might wind up. If you have any of these, it's certainly reasonable to see a doctor and discuss that because there's certainly ways to help. Now, a lot of men, and I'm guilty as anybody else, we will sort of ignore symptoms. We will sort of not necessarily like to see doctors, hope things go away, that sort of situation. But if you leave things be, I'm going to put this out there just to not to scare you, but just so you have some idea. This is not a good idea to kind of just let go. The frequent voiding we discussed as a possible complication, that's more of a symptomatic thing. Incontinence. Nobody likes to be wet, but what can happen is as the bladder is full all the time and the urgency, because the muscle's just so wanting to empty itself, it can just keep on squeezing and really start spilling over even some of the urine. And this can be a big problem and difficult to come back from at times. One can imagine if you're not emptying the bladder well, the urine's always sitting around. It's not a good situation, but it's a great situation for bacteria. So these men are prone to getting infections. In addition, eventually what will happen as the bladder gets more and more full on a constant basis, in essence, it's like pulling your muscle. Like if you pull your arm muscle, the fibers get torn apart and it takes a long time for them to heal. Similarly, the bladder muscle, it is a muscle, can get stretched, and eventually the muscle will just fail to contract at all because it's really essentially shot. And this is a very difficult situation for us to deal with because we have no medicine to make the muscle go, and we don't have a bladder transplant technology yet, which is really what these patients would need. In that case, you're stuck with chronic tubes and drains and just stuff that you really don't want to deal with. And in kind of the worst case end stage scenario, I've even seen patients who unfortunately, because everything is backed up in the bladder, it even backs up to your kidneys. And what does that do? It basically eventually starts hurting them. And you can wind up with even renal failure. Some patients, believe it or not, come in feeling pretty good, maybe peeing a little bit here and there, but they actually need dialysis. So these are some complications of BPH that need to be thought about. And let me just do that. There we go. So treatments. There are ways to help. The sooner the better, like with anything else. Earlier treatment, less of a problem, easier to deal with. The most common thing, we always start with easier things rather than more complicated medications. There's many medications that are available to reduce the prostate, to reduce the resistance of the prostate. And certainly this is something that should be tried first. Now, in sort of more advanced situations where medicines don't work, traditionally we have a procedure called a TURP, or transurethral resection of the prostate. There are various versions of this that are minimally invasive, in between invasive, or even more invasive, like actual surgery. But the most sort of common thing that things are compared against is what we call basically a roto-rooter. If you think of it that way, that there's a pipe going through that's too narrow, we have ways to open it. I just prepared a little video to give you some idea of what this entails. This is a doctor using our instrument through a telescope. This telescope is introduced through the penile urethra. This whitish tissue that's being removed and sort of scraped by this loop is prostate tissue. Inside here, the black part way distant there is the bladder with some urine in it. It's a sort of a big cavity in there. And the doctor now is trying to stop some of the bleeding. But you can see with this loop and some energy that's applied, we're able to slowly scrape it away. And if you think of it like plumbing, essentially when this case started, all that tissue was really tight. Now you can see it's really quite wide open into the bladder, and you can imagine how this patient will most likely have an easier time getting the urine out, as opposed to if all that tissue were grown into itself and really meeting itself in the middle here. All right. So that's a little bit about prostate and its growth from cancer, its growth from just benign growth, and what that can do. And the final thing I thought I'd touch on is a very common problem. It's a problem that's difficult for people to discuss, but it is present and it is something we can help with. So I thought I'd bring this up. It's erectile dysfunction. So we generally would define it, it's a situation and it's all relative. There's no one definition, but generally, if you cannot achieve or maintain an erection for satisfactory intercourse, you have erectile dysfunction. And this can, like I said, it can be varying degrees for different patients. A little bit about the incidence. So if you're a man with ED, you're definitely not alone. I mean, this is not anything that anybody goes and tells their friends about, so it may seem that you're alone, but statistically, a significant number of people do suffer from this condition. And there's tens of millions of men, and this is a condition where not only the patient themselves, but any partner they're with is affected in a negative way if they intend to have sexual relations and the man cannot, then more than one person is affected by this condition. So there are some risk factors, and these are things that, if you have something to think about, we have diabetes. The first couple here, I'm going to bring them in fairly quickly. These four are probably the most common risk factors for ED. So if someone comes in, these are things we want to see if they have. All of these have the same sort of pathway by which you might have erection problems, and these affect you by causing problems with your blood vessels. So diabetes, blood pressure, cigarette smoking, they affect vessels all through your body. Patients with any of these are at risk for heart problems, strokes, kidney problems, eye problems, all because of blood vessel issues. Similarly, high cholesterol, although that's less of a common thing than the first four. Some people have ED because of their medications that can cause side effects. This can be blood pressure medicines, heart medicines, something to think about if you're having trouble. I mentioned that because it's something that you can go over with your doctor, and maybe if they change a medicine, you might be better. Some of our prostate cancer treatments, radiation, surgery, they can cause erectile dysfunction. Patients with neurologic disorders, spinal cord injuries, they have problems through their body, and they can also affect the penile erections. There's a little bit of a misconception that testosterone is important in erectile dysfunction. I would say it can be something to be looked at, but it's not necessarily associated with the actual process of getting the erection. It can definitely affect your libido, your energy, that kind of thing, and your mood, but not necessarily your erections. And the big grab bag, the part that we really have a hard time dealing with, because there's just no way to quantify this from our end, is any psychological factors. There's so much that goes into sexual activity psychologically for men and women But there are definitely times when the patient might have none of the above. They seem really healthy, and yet they're having problems. And then you start to think maybe it's more of the psychological factor. It's a little bit more difficult to treat. Those patients might benefit from a sex therapist or something like that, but we don't really offer that through our practice. Now, I thought just for the sake of discussion, we could talk about how the actual erection occurs in terms of thinking of it through those risk factors and in terms of thinking what the treatments could be. Here we have a schematic view. This is a normal sort of flaccid or non-erect situation versus an erect situation here on the right side. And, just we're getting right to it. As a man becomes stimulated mentally, physically, that sort of thing, the nerves send signals to these red arteries that carry blood to the area. And what happens is those arteries expand and let blood into these little spaces. You see how the spaces got larger here. They're carrying blood now. They're full of blood. And that's how the penis enlarges, gets harder. It's essentially filling a water balloon, but the water of our body is the blood. And as it goes in, it basically starts to squeeze off some of the veins. All these blue veins get smushed because this area just takes all the blood, and these veins get smushed, and it keeps the blood in here. What will happen eventually is, after the completion of the activity, the blood vessels then, instead of being wide open, start to contract again, reducing the blood flow, and eventually the blood will leave the area. Let's see. All right. So now that we know a little bit about some of the risk factors and how it actually is supposed to work, these are some of the treatments. Again, as a general rule, you want to start with the easier things, especially down here. Most men will opt to use some medications. These are the famous sorts of things like Viagra, Cialis, that I'm sure most of you have heard of. These medicines work by, you take it ahead of time before you want to have your activity. And through their mechanism of action, what happens is these medications are a little specific for the penile blood vessels to induce them to open. And in so doing, the blood comes on in, and we have that process that we just spoke about. Now, these medications don't work for everybody. We need blood vessels that still have some elasticity that can respond to these medicines. And if that doesn't work, there are some other types of options. These are the next sort of two less invasive thoughts. One is called a vacuum erection device, and the other is penile injection therapy. So here's a picture of a vacuum erection device. Now this, I will say, in all my years, almost 20 years here, I don't think I've had maybe one man who found this to be that useful. In essence, this is a cylinder with a pump on it. And by pumping this, you're actually creating a vacuum inside this cylinder. And the vacuum will draw blood sort of into the penile area. So if you can't get the vessels to open and let the blood in, you can kind of, in essence, draw it in by the suction pump device. Problem is, once you release the vacuum, the blood wants to leave again. So what these men have to do is use this, in essence, a rubber band that they slide off and put at the base, and it's extremely uncomfortable for most people. The band is intended to keep the blood in the penile area, and I think most men find this to be almost kind of defeating the purpose of things. Penile injection therapy is another. This is actually a fairly effective way of treating erectile dysfunction. That the famous sort of Boston Medical Group, I think, does this sort of thing, but we certainly help patients in the office too. This is a way you can see of administering medicine directly into the shaft of the penis. And here's sort of a side view. We're aiming for this area, these two guys that kind of fill with blood they're supposed to fill and cause the erection. Down here, we have the urethra, which carries the urine and the sperm and stuff, and we want to stay away from that. But it's a real small needle, and it goes right in there. Again, this is something you take right before activity. You can do it yourself. Your partner can help you. It's not painful in most cases. This needle is tinier than the blood drawing needles. It's an insulin syringe with a really tiny, tiny needle. And once you get over, so it's a really weird concept, but once you get over that, and most patients find it's a very doable kind of thing, and it is more effective than the pills in general. Finally, if none of these work, or maybe you're not crazy about injections, we do have a certain number of men who are interested in penile prosthesis surgery. And I'll tell you a little bit about that. Before I leave this slide, this is a sort of another common question we get asked. There's no real revascularization kind of surgery. So like maybe sometimes like for legs, you know, if there's decreased blood flow from the arteries, they can do a bypass or a cardiac bypass to restore blood flow. The vessels in this case are so small that unfortunately we have no way of creating new blood flow because they're just too small to create bypass. Unless you've had major pelvic trauma to some of the larger vessels, sometimes that you can have surgery to fix those. So I'll just finish up a little bit by talking about what a penile prosthesis is. I tell my patients, you know, it's not for everyone, but it's a very effective treatment. There's different kinds of prostheses. This is a picture of one before we implant it. There's two rods here that are essentially water balloons, and they're placed in the penis to mimic the natural action of blood going in there. We have a ball full of liquid up here that we implant. I'll show you where that goes. And there's the pump, the famous pump that sits in the scrotal area near your testicles. Here's a diagram of what eventually things look like once it's implanted. If someone happens to see, if you have this and someone sees you in the locker room or in the shower, for all intents and purposes, no one will know it's there, just from a visual standpoint, but you can certainly feel these things inside. Most importantly, you can feel this pump. So a flaccid state, you would have a full thing of liquid here, the penis kind of down like that. These two rods or cylinders are empty. By squeezing this ball here, essentially it brings water from here, through the actual pump and into these two rods. So these start to fill with water now, or saline. In essence, liquid goes in there, not blood, but this liquid that we put in. And you can imagine it will make things firm. There's a button here on this pump so that after you're finished, there's a way to deflate things so you're not walking around in an embarrassing sort of situation. And by pushing this button, it lets the water back out of here and this ball will fill back up. So this is a very effective thing. There's certain risks. There's certainly healing that needs to go on from the surgery. There's risks of infection and that sort of thing. But by and large, it's an extremely effective treatment. The sensation, the pleasurable sensations, orgasm, all that stuff is preserved. And it will give a man who maybe just doesn't have the ability to be intimate, that ability again. So that's all I had prepared. It's a little brief overview of some of the common things that we deal with. Urology also encompasses a whole bunch of different other things, different kinds of cancers besides the prostate, kidney, bladder. Kidney stones are a big part of what we do, erections, infertility, and urinary problems for men and women. Women, of course, do have a lot of urinary problems, but I thought that that would be a little bit too much to go over all at once here. But anyway, that's what I had. If there's any questions, I'm happy to try to talk to you, make it very informal, and thank you for listening. I think we can, if you like, we could use the chat box, or you feel free to chime in, or if there's no questions, that's okay too.
I like to believe that, well, I do believe strongly that our art should be relevant. It should have a purpose. It should drive out the society forward. It should educate our audiences. So this is a really special.
All right, it does not look like we have any questions. And if anyone does have any questions, please feel free to chime in or type your questions down in the chat box. I'll give them another couple minutes. All right, so if there's no other questions, thank you everyone for coming tonight. Thank you, Dr. Chang. Thank you, Nikki, for organizing this event. And thank you everyone for coming out this evening.
Okay, thank you.
All right, have a good night, everyone.